In the United States, where public trust in institutions has fallen to all-time lows, the pandemic has hit harder than anywhere else. Now, as the COVID-19 crisis extends into a second year, what barriers does that distrust pose to mitigations and recovery efforts, starting with the largest vaccination push in U.S. history? So my first question is, where does trust already exist and how do we leverage it? Dr. Murthy, let's start with you.
Well, thank you so much, Mia. Trust is such an important issue because in a public health crisis, whether it's a pandemic or any other sort of challenge, the most important resource you have is public trust. Without it, you really can't achieve the objectives you need, whether that's public education efforts, whether that's getting people to take a vaccine or take other measures to protect themselves. But trust still does exist in communities. The challenge is that not everyone necessarily trusts the same people. And trust is also situation dependent. You may trust your cab driver, for example, to get you to the airport, but maybe not necessarily to water your plants and watch over your house when you're away. So many people, though, have someone or some group that they trust in their lives. It may be their family and friends, their faith community, maybe their doctor, it may be their local elected leaders. And engaging these messengers is really important to getting messages across, whether it's about vaccines or other health matters. And that requires true partnership, bilateral partnership, two-way partnership. And ideally, you build those partnerships before a crisis arrives so that they're there and ready to use and lean on and rely on during a public health emergency.
Mayor Baraka, can you expand a bit on how all levels of government might better partner with community organizations to build better long-term relationships and trust?
Well, I think those relationships begin before the crisis. And I think a lot of folks scramble at the last minute to try to put these organizations together, put these groupings together, start to collaborate. And it's difficult to build trust even in the middle of a pandemic or a crisis. People still don't know how to work together. I mean, don't know the inner workings of organizations, don't know who to contact, who's in charge of what, how to navigate that. And so it's always important to build trust with organizations early on, to have a regular practice of meeting with community organizations, talking to people, having an open door policy, making sure even if you disagree, that people know you're transparent in what you're disagreeing about. And so those relationships have to be built over time. It's a mistake to think that you can do that in the middle of a crisis.
So that really leaves us in a challenging position, right? Those relationships haven't been built, but if we're going to get the public to get vaccinated and to do the other things that are necessary to get COVID under control, are there things that government can do right now to quickly build some of those bridges and repair some of the damage that's been done because of lack of trust?
Well, I think that ultimately we need to be talking to the community as much as we possibly can. Having full, transparent discussions and not really trying to push things on people. I think the kind of practice of trying to tell people, oh, you have to take this, you must do it, or else is wrong. I think first acknowledging the fact that the relationship has been broken for some time and that it needs to be repaired. Two, being really honest about giving people the facts and information about what is and what was and what's involved, and allowing people to come to these conclusions at their own pace. And I know there's a sense of urgency, but we made this bed, right? So there's an urgency to get people to get vaccinated, and I understand that. I have the same urgency. But we also have to take into consideration history and broken relationships, and you can't rush that. You have to allow people the opportunity to become comfortable with what's happening on their own, which means that you may have to have more conversations than you initially planned to have. You may have to have, multiple conversations over and over and over again with people to be able to get them to be comfortable with trusting the organizations, the system. And some of it is not historical trust. Some of the trust is trust that doesn't exist now because of problems that exist today.
For sure. And one of the things that you just brought up, Mayor Baraka, that I want to ask you about, Dr. Murthy, is about how information and facts are shared. One of the most effective tools we have in fighting COVID is masks. In the beginning of the pandemic, we saw both missteps when it came to communication about mask wearing and the politicization of mask wearing. So if you could go back and redo it, what would you do differently that we missed the first time?
Well, Mia, it's a great example, and unfortunately, the history of public health is full of examples of interventions that science says work, but which we haven't been able to do as effective a job, at getting out into the community and getting people to adopt. And that's not necessarily people's fault. It says Mayor Baraka was saying it can be the result of longstanding challenged relationships and distrust that has built up over years that we may not have acknowledged. But I think that the idea the way you want to address this initially is you want to, number one, start with listening and understanding people's concerns because they're not all the same. And one of the, I think, potential pitfalls we run into is assuming that everyone has the same concerns. The second thing is we want to acknowledge what their concerns are and validate them. See, too often I think public health makes people feel judged. Judge if they're not doing exactly what we say that they need to do without acknowledging what their concerns are. And I think the third thing we have to do is work on getting people to yes on the things they want to do instead of always saying no. I mean, I was aware when I served as Surgeon General before that people sometimes would assume that I was going to be the one telling them everything they couldn't do, like don't eat that piece of pie, don't eat that dessert you really like, don't have that other drink. Whereas I think what we have to do with public health is more frame it as a set of tools that can help get people to where they want to be, whether it's getting together with friends. Can masks allow you to do that more safely? Well, yes, if you can get together with people, distance and masks in outdoor settings, that is dramatically lower risk. And a mask can be a way then to form a bridge, essentially, to social connection. It's always important to have messages that are informed by science and not by politics. That's been a challenge in the past. And you've got to ensure that you've got a diversity of messengers because the message matters, but sometimes the messenger matters even more. And that's why these community partnerships are absolutely essential to good public health work.
Much of your work over the past couple of years has looked at loneliness and the public health consequences of weakened social connection. And in my own work, I've seen that loneliness is in many ways an outgrowth of some very American ideals around individualism and an understanding of freedom that kind of rejects interdependence and connection. How should we be thinking about combating toxic individualism in the context of a public health crisis like COVID?
Well, Mia, it's a really interesting question, and I know you've done such important work in this space. I think there is a thread of individualism that runs through the American experience, but there's also a strong thread around community. And it's interesting because it's not that relationships aren't important to many of us, but for many of us, including me, relationships have just drifted lower on our lived priority list, not on our stated priority list. We'll always say that our relationships to our family is the most important and our close friends, but in how we live our life, where we put our time, attention, and energy, for many of us, again, myself included, work often has crept into first place just based on time, energy, and effort. But on a societal level, I think what we've also done is we've allowed the balance between the individual and the collective to swing away from community, perhaps too much. And I think what that's meant is that we cherish individual accomplishment and effort. We tell stories about the individual entrepreneur who built an extraordinary company or the most important athlete on a football team or basketball team. But we often don't sufficiently recognize and lift up the extraordinary progress that's made possible by collective effort. And I think we change this through the stories that we tell, the efforts that we reward, and through the lives that we choose to live. And I think that the life that I feel called to live and that I feel as a society we need to move toward is one where we truly do prioritize people and relationships, where we put people first. But we've got to get there one by one by living that in our own lives and ultimately by telling those stories in our media, in our speeches, in our communities, because the stories we tell are essentially communicating what we value. And we've got to communicate that the collective, that the community truly does matter, especially in moments like this.
Dr. Henning, I want to get you into this conversation. I think that many would argue that in addition to flawed and confusing messaging and some of the challenges of American culture in particular, we also just don't have robust public health infrastructure. And that goes beyond our ability to respond to infectious disease. What are the broader public health investments that we need to make in order to better position us to fight future crises and to prevent them from happening in the first place?
Mia, thanks for that question. We've been working on some of these issues for a long time, long before the pandemic actually hit. And when people think about public health, they often think of historical pieces like smallpox eradication or polio, or perhaps more recently Ebola virus outbreaks that have occurred. And now, of course, COVID-19. But actually, there are many other issues that are very front and center to public health, and they include things like all of the chronic diseases that are so amplifying this current pandemic. So things like high blood pressure and the control of high blood pressure, obesity and overweight, physical activity, and the lack of physical activity, diabetes, cancer, heart disease. These are all public health issues, and these are all things that many of the very same communities that are most impacted right now by COVID-19 are also very highly impacted by. And this issue of trust really extends to these chronic diseases. Folks are not being met where they are. They're not being encouraged to seek care. They're not being supported in many of the ways that we need them to be in order to address these really enormous killers. Smoking is another one. Smoking is tobacco use is a major killer still in the United States. And these are all public health issues that have equity issues attached to them, and that we really have this opportune moment right now to address in this COVID pandemic.
So the question is, how do we actually build the infrastructure we need to address not just infectious diseases, but all the other kinds of public health issues we have? And is part of that about actually expanding how we understand the role of public health?
Yeah, I think there's a lot of work that could be done to bring the public along in terms of their understanding about what public health is. But I also think public health has a lot of listening to do. I mean, what are these obstacles to doing, to providing better services and to engaging the communities that are most affected? We have lots of answers in public health, but we don't have lots of listening all the time. And I think this might be the moment when we really want to double down on engagement with those communities. We've got the attention of the public, of the policymakers in this COVID moment. Now we have an opportunity to go even further and really address some of the underlying health issues that are so seriously impacting vulnerable communities.
So, Mayor Baraka, let's get real. The vulnerable communities that we're talking about are communities of color, low-income folks, disabled folks, and there are historic and present-day reasons for all of these communities to legitimately distrust our healthcare systems. So I have a two-part question for you. The first part is, what should be happening right now to make sure that people who have been marginalized and exploited are not left behind when it comes to vaccines? And secondly, what are some of the things that our healthcare systems need to do, not just to build relationships moving forward, but to repair relationships with Black folks, Indigenous folks, and other communities who've experienced harm from those systems?
I mean, look, places like Newark. I mean, African-American women are 4 times more likely to die giving birth than anybody else in the state. And we have one of the highest infant mortality rates in the country, right? So that also contributes to the mistrust of people taking care of us. I think the first thing is access. So it's not enough just to talk about what's going on, and we have to have access. So access to health systems, to wellness. So we have to make sure that the vaccine is available to people in the community, that we're not just setting up these big sites. 50% of the people in Newark don't even drive, right? So when they first started these drive-in testing sites, you wiped out half of my city. So we had to figure out how to do walk-ups and do pop-ups in various communities and neighborhoods, in church parking lots, and the parking lots of stores, and parking lots of schools. And so the same thing in terms of the vaccine. Those things have to happen. We have to make it accessible and put people involved in the processes who come from those communities that people trust. You have to bring those people involved in the processes inside as nurses, as administrators, as practitioners. They have to be involved as credible messengers, right? All of those folks have to, you get the the religious community involved as well, as we started to do in Newark. Start getting them vaccinated, allowing them to be credible messengers. Those things have to happen. And I think with the public health infrastructure, period, we have to get away from this kind of emergency room model and go towards the kind of public health clinics in our community, because we don't have access to primary care physicians. So I listen to the CNN and they always say, talk to your doctor, ask your doctor this. Well, the doctor in our community is the emergency room. So there's no primary care physicians. And so we have to set up clinics and opportunities in these neighborhoods in order to get people acclimated and give them access to right healthcare. The last thing I want to say is that healthcare in our community is crisis oriented. People go to the doctor when they are about to kill over, pass away, super sick, falling down, and there's not a kind of emphasis on wellness. And I think that all of those other issues, the high blood pressure, the other kind of things that led to the comorbidities, this whole idea about wellness has to be taken seriously in our communities to get people to trust that you're trying to keep them alive or let them have a great life, not just care for them while they die.
I really appreciate all of that. Part of what I hear you all saying is that public health actually needs to be for the public, but it also needs to be of the public, right? It's not just that we have a group of people over here who are our health care practitioners and experts, and that they get to decide what a community's priorities should be and then go apply their methodologies and practices to that community, but that we need a more integrated approach that is responding to a community's self-identified needs, and that the people from a community need to be part of the health structure that is serving that community. I think another thread I want to lift up is that we're not just talking about one-on-one relationships, like the kind we might have as individuals with our doctors, but public health is also about collective relationships. This is where we think about things not just like heart disease or smoking, but also things like access to high-quality housing and food. Those are all the things that we really need to support our wellness. Thank you so much to all of my guests.